lectures on the topic. Radha, please.
Good morning, everyone. What I will be discussing in next maybe 10 to 12 minutes is what should be the holistic approach actually first to diagnose, because the diagnosis is the key for any management, and then management of heart and kidney disease in a type 2 diabetic patient. We all know that we are having a huge burden of not only type 2 diabetes, but we have a huge burden among the type 2 diabetic patients of the cardiovascular disease. It does not just lead to increase into the mortality, but decreases the risk of the hospitalizations. And if you see the type 2 diabetic patients in India, 1/3 of them are having albuminuria, and diabetic patients are more prone 10 times compared to non-diabetic patients to have the chronic kidney disease. And if you go by the this very interesting data, early CKD actually reduces the life expectancy by almost 7 years in females and 6 years in male. Diabetes alone would lead to reduction into life expectancy of around 12 years in female and 10 years in males. And early CKD with type 2 diabetes is 17 years life expectancy reduction in female and 15% in males. And it does not just increases the chance of the early mortality, but increases the chance of the congestive heart failure. So diabetes and CKD, even early CKD, is like a ticking bomb which can explode anytime, and it leads to almost 5 to 10 times increased risk of the CHF and the mortality. So first, how to identify the dual risk of CKD and CVD early in our type 2 diabetic patients. During our MD days, we used to get the microalbuminuria test very routinely as a marker of the renal insufficiency. Subsequently, we established that microalbuminuria or albuminuria or increase in urine albuminary excretion ratio is a marker of the CVD also. But with the SGLT2 inhibitor coming into play, we are talking only about the eGFR, and we are probably forgetting about our time tested old albuminuria. Like you can see here, this patient, if you put him type 2 diabetic patient with eGFR of 64 and his risk of progression of the kidney disease, he comes into the low risk category. But as we include the microalbuminuria or albuminuria in this patient, which is around 352, he is at a high risk of worsening of the cardiovascular disease as well as the CKD. So why the USER is so important? And we all know that there are many common risk factors for CKD as well as the heart disease in a type 2 diabetic patient, like hypertension, diabetes, obesity, chronic inflammation, and because of the damage to the glomerular filtration barrier, there will be endothelial dysfunction, mesangial expansion, basement membrane thickening, podocyte apoptosis leading to albuminuria, and it has a shared pathogenesis for chronic inflammation, changes in the hemodynamics, oxidative stress, and endothelial dysfunctions leading to both cardiovascular as well as the kidney dysfunction. And this is a very interesting side that even all-cause mortality and cardiovascular mortality is a large study of more than 3.5 lakh populations. Even eGFR of 30 increases the all-cause mortality and the cardiovascular mortality. And you can see here the risk starts increasing when the USER start increasing even from the 10 to 30. So we should not be forgetting the importance of the albuminuria in a type 2 diabetic patient, not only as a marker, but as a treat to target in our type 2 diabetic patient. And that's why all the major guidelines recommend both eGFR and UCR in otherwise healthy type 2 diabetic patient at least once in a year if they are normal. And of course, there are compelling reasons like recurrent urinary tract infections, nephrotoxic drugs, we may be, or patient already having albuminuria, we may be repeating it more frequently, but we should be taking some pinch of salt, that we should be avoiding the UTI infection, significant systemic infection like in fever, significant uncompensated heart failure, mild hyperglycemia. Sometimes menstrual females also are reported as having the albuminuria positive, and unaccustomed exercise within 24 hours, we should be repeating the presence of the albuminuria after all these risk factors are corrected. So are all the drivers of the CVD and CKD progression are being addressed with the current management strategy? We all know the pathophysiology of kidney as well as the heart failure is hemodynamic changes, metabolic changes, and it unaddressed until now was the inflammation and the fibrosis. All this leads to the kidney structural changes like tubulointestinal damage and inflammation, glomerulosclerosis, mesenterial expansion, glomerular hypertrophy in the cardiac cells, leads to myocardial fibrosis, atherosclerosis, vascular stiffness and ventricular hypertrophy, all contributing to ultimate unfortunate significant kidney and heart failure. So the reason of inflammation and fibrosis is the presence of the MR overactivations in a type 2 diabetic patients, and we have got a good options for the hemodynamic and the metabolic change disarrangements for the progression of the CKD as well as the heart failure, and now we got a good agents available with us for the inflammation and fibrosis prevention, that is the taking care of the MR overactivations. So despite the RAS blockade and the SGLT2 inhibitors, we all know that all the trials when were conducted were on top of the standard of care at that point of time. Like when RAS blockade came, there was practically glycemic control and the hypertension control was the baseline. On top of that, if you add the RAS blockade, then it leads to significant reduction into the worsening of the heart failure. When the SGLT2 come, it was renal outcome trials included the patients who are on an optimal RAS blockade therapy, and in spite of all this, there is a significant residual risk which needs to be addressed, just like a cardiovascular risk reduction. In spite of multiple therapy targeting for the prevention of the atherosclerotic cardiovascular risk, there is a residual risk. So what is a Finreron? How it is different from the existing steroidal MRAs? We all know that Finreron is a selective non-steroidal MRA which blocks the MR overactivation, slowing kidney and the cardiovascular disease progressions, ultimately leading to some hemodynamic benefit, inflammation, fibrosis benefit, reduction into the albuminuria as early as within few weeks of time my subsequent speaker is going to discuss, and ultimately might reduction into the cardiovascular and the heart failure morbidity and the mortality. How it is different from the existing aldosterone antagonists like spironolactone and eprilon? It is highly selective, it is a bulky, it is having a least CNS penetration, no gynecomastia in male, short half-life, blood pressure reduction is moderate compared to spironolactone and eprilon, and it is indicated at present with the CKD associated with the type 2 diabetes in the presence of the albuminuria. So in ARTS trial, Finreron was found to be well tolerated with less patient experiences hyperkalemia versus spironolactone. So naturally, it is more selective, leading to less chance of hyperkalemia. As the previous talk, somebody had asked about the risk of the hyperkalemia with the spironolactone. Compare that with the Finreron, there is a significant less risk in this study, ARTS study, where a patient had already heart failure with a reduced ejection fraction and presence of the CKD. So spironolactone has actually failed to show any renal or the cardiovascular protection in patient with the CKD. This is a recent study, 1 year back, BERAC-D study in a 1,300 plus patient with stage 3B CKD, and it showed that primary endpoint, which was time from randomization until first occurrence of the mortality, HHF, stroke, heart failure, TIA, PAD, or first onset of any condition which was worsening, and spironolactone was not associated with improvement in the kidney function, and it was having a more chance of discontinuation due to hyperkalemia or significant drop of the eGFR. So compared to other MR antagonists, this is found to be quite superior as far as the safety and efficacy is concerned. I think in a subsequent 2 talks we will talk about its robust data in the heart failure prevention, in the prevention of the worsening of the renal failure, alone or on top of the patient already on the empagliflozin. Thank you very much for your patience hearing. So early stage CKD and CVD management is often missed, and urinary albumin creatine ratio and eGFR are both the cornerstone of the investigation right at the onset of the type 2 diabetes. And despite the RAS blockade and SGLT2 inhibitor and optimum care for the type 2 diabetes with the CKD, patients are at risk of the CKD and the CVD progression. And Finreron is a selective non-steroidal well tolerated drug with a proven safety, and more importantly, the efficacy data, which I think is going to be discussed in the subsequent talks in this symposium. Thank you very much for your patience hearing.
So next speaker is Dr. Kamal Sharma. I know him personally and professionally since a decade, working together. Going to be excellent talk, I know, sir. Please, sir.
So, good morning everyone. Parag Bey has given me 3 additional minutes, so I probably can now speak for more than the allotted time on the lighter note. So, probably we'll use that time, Parag Bey, for discussion. I'm going to talk about practical considerations from Fingalone Cree takeaways from landmark trials. What we must understand that we were in an era, you treat diabetes. How do you treat it doesn't matter. I mean, you just give any anti-diabetic, as long as sugars are good, you're fine. Then came era, you choose between a group of drugs. You choose SUs, you choose DPP4s, you choose SGLT2. Same way in heart failure, you choose group of drugs for heart failure. Then came an era where you have to distinguish between molecules within a group. Like the previous session, we were discussing one DPP4 versus the other, and I was sitting with my senior friend and colleague, and he was asking, sir, EMPA or DAPA in heart failure, how do you decide? And I was discussing again subgroups. Same is happening probably with the MRA now. And we need to understand that what is proven as an evidence for one molecule, we probably were extrapolating that for the whole class, and that probably doesn't hold true. So when we look at data sets which come out in phase 3 or 4, the root of it lies in somewhere in the initial phase of drug discovery. With AI coming in, probably you will have a lot of molecules popping up. If you've gone through the science, you will see that the structural way the molecules are being evaluated. Now they are just going to ask AI, shall I replace fluoride with chloride, or a carbon ring with double ring, maybe carbon ring with a benzene ring, and small changes, which of them is causing what side effect, gynecomastia by this ring, remove this and add this. Something like that is going to be very quick, and probably every new conference you're going to hear one new molecule in next 5 decades, next 5 years to come. But basically, Fingalone had its group of trials which looked into what were called as ARTS-DN and ART-HF, where they looked about its tolerability versus spironolactone, reduction in albuminuria, and its comparable efficacy with eplerenone. So ethically, you cannot come with a molecule which is anything at least inferior to the standard care available in the market. So we all know MRA's Raoult's trial established spironolactone as one of the therapies which needed the least number to treat a heart failure in the shortest duration of time. When you have to compete with a molecule like spironolactone in Raoult's trial, which showed mortality reduction as early in class 3-4 failures, a failure patient during same hospitalization by just 16 patients being given a therapy, you need to be robust in that comparison. When you launch a molecule, you need to show that you are at least comparable to it. And that's what the ARTS actually did, which showed that it did not increase hyperkalemia in patients with CKD in heart failure with reduced ejection fraction. Diabetic CKD in ARTS-DN did not. There was dose-dependent reduction in albuminuria, and in heart failure with CKD in ARTS-HF, there was comparable. So these laid foundations to 2 important trials which are called as Fidelio's DKD and Figaro DKD. Fidelio basically looked at kidney failure disease progression in patients with diabetic kidney disease, CKD with type 2 diabetes, 5,700 plus patients, and Figaro looked at cardiovascular mortality morbidity in the same group of patients, which were CKD and type 2 diabetes, of 7,437 patients. Now, when we look at the club data, evidence for the Fingalone is documented with the complementary effects in the kidney and CV endpoints. I think we all, when we entered medical school, we thought of that you need to become specialist. More specialist do you become, more higher you are in the hierarchy. And somewhere in that, we probably lost ki wo Arjun ko machli ki aankh hi dikhni chahiye mein. We actually stopped looking at the whole fish. We actually became so specialist that the left heart specialist does not know what the right heart is doing, the right chamber. And that's not the case. We need to be first a generalist. Your specialty does not mean you stop being a generalist. When you started chasing diabetes, you forgot that it actually ends up causing kidney disease. Kidneys and diabetes together goes into what you call now the CKM, the cardio-kidney metabolic modulation together. And that's why when you're looking to treat diabetes with kidney disease, you're also looking to treat cardiovascular outcomes. So basically in the Fidelio and DKD outcomes, Finrenone versus placebo was compared looking at the composite endpoint of efficacy of reduction in kidney failure, which is more than 40% eGFR decline or kidney-related death. And in Figaro DKD, they looked at the primary endpoint. Here, the primary and secondary endpoint were cross-changed between the two subgroups. So practically, the primary endpoint of one trial was secondary endpoint of the other. And in Figaro, what was the primary endpoint was time of CV death, non-fatal MI, non-fatal stroke or heart failure hospitalization. What secondary endpoint of Fidelio. So when you combine the two, actually you're looking at the composite of outcomes which are merger of the same. Fidelity, again, look at, hence the combination is called as Fidelity, which looked at hence the key outcomes of time to CV death, non-fatal MS, stroke, heart failure, hospitalization with a pre-specified pooled analysis in stage 1 to 4. Remember, stage 1 to 4, if you were to look in most of your diabetic patients, if you look at USCR and eGFR of anything below 90, practically 90% of our kidney patients are this subgroup of patients. 57% time to kidney sustain more than 57 eGFR decline or kidney related were the composite endpoints that were looked into. So Finrenone demonstrated in this subgroup significant reduction in CV and kidney outcomes in phase 3. The main age group in this group of patients we look at was 65, blood pressure was 137/76. Very often you would call them as so-called not very high, but remember 46% of them had some or the other form of CVD, and majority 99% patients were on RAS inhibitor already. So this is one of everybody's favorite therapy. Every diabetic or every nephrologist or an endocrinologist would put a patient on a sartan most probably, and practically everybody would be receiving one or the other form of RAS blockade. Also, they were 6.7% and 7% on SGLT2 GLP-1 analog. Remember, this is before these two established as the pillar therapy for kidney disease. Even in that subgroup, there were these patients. Look at the outcomes. There was 14% reduction in CV morbidity and mortality and 22% reduction in heart failure hospitalization, with 32% reduction in USCR with a change from the baseline, with 23% reduction in CKD progression and 20% reduction to occurrence of end-stage kidney disease. So it improved not only CV and heart failure outcome versus placebo, kidney outcomes my next speaker is going to take care. So I'm going to focus about the cardiovascular reductions. There is reduced risk of first heart failure hospitalization. So why do you treat diabetes or why do you treat kidney disease for that matter? Because they don't die, most of the kidney patients die from cardiovascular outcomes. They don't die of kidney failure per se. And there's 32% reduction in new onset of heart failure in these subgroup of patients. So when you pick up early kidney disease in diabetic patients, you not only prevent kidney disease progression, but actually you prevent their cardiovascular outcomes getting impacted strongly, and that's why ESC 23 recommended it as a therapy of choice in this subgroup of patients. So it's recommended to reduce heart failure hospitalization with acute kidney injury groups, almost the same, blood pressure reduction more, of course no impact on gynecomastia, minimal clinical impact as they say in terms of negative outcomes, no change in A1C, adverse events were practically none, and robust potassium management strategy guided by regular potassium monitoring with no hyperkalemia related deaths in more than 13,000 patients over 3 years of median follow-up, which is a big number, which is a big worry for the old generation the steroidal MRAs as we call. So it has consistent kidney benefits across irrespective of SGLT2. When you look at the subgroup analysis, whether the patient was on SGLT2 or not on SGLT2, GLP-1 or no GLP-1, ASCVD present or absent, baseline A1C, insulin, diabetes across the stage 4, age, gender, blood pressure, there was no difference. If you look at the practical consideration, target of 20 milligrams as a dose dependent in a USCR reduction, at 10 mg, if the eGFR was below 60, target was of course to go to 20. If the starting of eGFR was more than 60, you can go with it. In the ARTS-D and the Finrenone reduce USCR at 90 days in a dose dependent manner. So ideally, you should try to go up to 20 milligrams in most of these patients. In the algorithm to minimize the risk of hyperkalemia, simply you can start this therapy at 5. Not 4.5 unlike the other MRAs. Up to 5 you can start this. If the eGFR is more than 60, start directly with 20. eGFR is below 60 or up to 25. Remember, other MRAs you are always worried below 45. Here you can go up to 25. You can monitor potassium at 1, 4 and 4 month and then 4 monthly. If potassium levels are below 40, 4.8, you need not do anything. Even up to 5.5, you just monitor. Only above 5.5, you need to be worried and stopping the therapy. So there are some recent evidences that have emerged, and this is called fine arts. This is one of the most important therapies that has been coming. There is increasing prevalence of preserved ejection fraction. Now, if you look at the heart failure in kidney patients, they don't just have reduced ejection fraction. A lot of these patients are underdialyzed. When you have reduced ejection fraction, most of these patients, when they have good echo on systolic function, still have elevated BNPs, and we believe it's because of declined eGFR or false rise. It's not so. These patients have heart failure with preserved ejection fraction. It's a number one high morbidity, and 50% of mortality within 5 years of diagnosis can occur, with a 15 years of reduction if the EF is between 40 to 55%. So despite current treatment, we don't have many therapies for heart failure with preserved ejection fraction. 1 in 5 patients get admitted within 1 month. More than 50% will get readmitted within 1 year. There is huge unmet need in patients with CKD not on dialysis, who require to be prevented from getting admitted because of poor outcomes. Right now, amongst so many therapies on this side that you have for reduced ejection fraction, for preserved ejection fraction, very few therapies are there. You have diuretics, but they don't reduce mortality, only symptomatic improvement. SGLT2 is the only therapy, and there was a lot of noise about it. ARNIs had borderline result. In Paragon HF, it missed the statistical significance by a whisker of P of 0.06. And still we call it 2A as a therapy of choice. So what choice do we have? This is where fine arts makes a very important message. It evaluated patients with EF more than 40%, and they were diagnosed class 2 to 4 with NT-proBNP more than 300 in sinus rhythm, just 300, remember. Started on Finrenone, Renal multicentric randomized placebo-controlled phase 3 trial with a composite of CV death and non-fatal recurrent heart failure hospitalization. Finrenone had hospitalization, if you look, less than 7 days were present in 45%, more than 7 days to 3 months in 20%, sorry, the other way around, and majority of the patient had more than 3 months of heart failure hospitalization in their background history. Lot of patients on diuretics, beta blocker, ASARB, ARNI, CCB, SGLT, GLP-1, everything on the background, but Finrenone on top of that reduced 16% relative risk reduction of death and heart failure hospitalization. And this curve starts separating at first month. You start the therapy, and at 1 month the therapy will reduce the event rate. Hyperkalemia, slightly manageable, low increase in the potassium levels. Most of these patients had on the more than 5.5, but otherwise blood pressure less than 100 in compared to placebo because of antihypertensive. So this is the one therapy across 17 subgroup which checks all boxes, irrespective of age, gender, region, BMI, race, NYHA, EF, hospitalization, diabetes, AFib, potassium, eGFR, NT-pro, USCR, systolic blood pressure, irrespective of SGLT2, ASARB, all across subgroup, Finrenone reduces heart failure hospitalization. It's the first and only MRA in patients with preserved ejection fraction to demonstrate 60% relative risk reduction of CV outcomes of number of heart failure hospitalizations and death in patients with EF more than 40%. This is regardless whether you have SGLT2, what is your LV. EF, where benefits for secondary outcomes are also there, and it's a well-tolerated therapy. So thank you very much. With this, I would hand over the session back to Chair so that we can hear kidney aspect, and then maybe we can take on question answers at the end.
Good afternoon. We welcome Dr. Siddharth Mawani sir for the talk on Finrenone on CKD. He has principal investigation in my trial and private practice since last 15 years. Over to you, sir.
So good afternoon, respected senior dear friends and colleagues. I'm chairperson on DIAS, and as expected, super lecture series by Dr. Parag Shah sir and Dr. Kamal Sharma sir. So commonest cause of death in CKD is heart, not kidney, and as there is a progression of CKD from stage 1 to stage 5, incidence of kidney cardiovascular event, they increases gradually. So any molecule, now as multiple studies have shown and as has been discussed by Dr. Parag Shah in first session, urinary albumin create ratio is one of the most important and surrogate marker for progression of chronic kidney disease and development of cardiovascular dysfunction in this group of patients. So any molecule which can reduce urinary albumin create ratio can be helpful for prevention of cardiovascular event and progression of CKD in this group of patients. So what our current guidelines are recommending? So there are three pillars apart from control of diabetes and blood pressure, and after lifestyle modification there are three core treatment pillars, drug pillars, there are there. So one is well-established RAS inhibition. After IDNT and renal trial, they are there as a standard of care for treatment of type 2 diabetic CKD patient. After that, SGLT2 receptor inhibitor came with proper data with Renal, EMPA CKD, DAPA CKD, and recent trials on say urinary albumin create ratio reduction. But even after using of RAS inhibition with SGLT2 receptor inhibitor, there are multiple patients who are still on progression for development of CKD and developing cardiovascular event. So ultimately it was found that there was a inflammation which was playing role, and there was rise in mineralocorticoid receptor receptors in CKD population, and that's why there was a invention of mineralocorticoid receptor antagonist, that was a phenomenon. So when to use which molecule is still not clear. So multiple guidelines are there. What they are saying, ABCD UK say you can add phenomenon whenever you are not getting proper response in reduction in proteinuria despite use of maximum tolerated dose of RAS inhibition and SGLT2 receptor inhibitor. KDIGO 2024 says you can add phenomenon to RAS inhibitor and SGLT2 receptor inhibitor for CKD as well as cardiovascular benefit. ADA 2025 says the phenomenon can be used with SGLT2 receptor inhibitor interchangeably or together for progression of for prevention of progression, and ESC 2023 says that it can be used with or without SGLT2 receptor inhibitor. But there is still confusion whether we can use these two molecules simultaneously or not. So this is one good study which was published in American Journal of Nephrology, said if you use RAS inhibition alone versus combination of this therapy, you can have benefit of event-free survival, particularly hospitalization because of heart failure by more than 3.1 years, all-cause mortality by 2 years, kidney failure by more than 4.9 years, and composite kidney outcome by more than 6.7 years. So definitely combination is helpful, but can we start this combination and can we start de novo or not? So for that there was some study which was necessary, and confidence trial came out at the right time. It is recently published in July 2025 article in NEJM. So this is randomized, double-blind, double-dummy, multi-centered across 185 sites across multiple countries, 3-arm parallel group study. Around 818 population was there with 1:1 dilution randomization. After 14 days of screening phase, treatment period was there. So 3 groups were phenomenon 10 or 20 milligram with empagliflozin of 10, phenomenon 10 or 20 with placebo, and EMPA with placebo. After 6 months of therapy, study ended and they were followed for another 30 days. Primary efficacy endpoint study were reduction in albumin create ratio from baseline at 180 days in combination versus EMPA group, combination versus phenomenon group. Secondary safety endpoint studied were eGFR changes and development of side effects like hyperkalemia. Eligibility criteria were type 2 diabetic patients with HbA1c less than 11, estimated GFR between 30 to 90, urinary albumin ratio more than or equal to 100 and less than 5000, and potassium less than 4.8. So diverse range of patients with high comorbidity burden were there. This is demography of this group of patients. 75% were male, 25% female, mean GFR 54, HbA1c 7.3, mean age 66.5, urinary albumin ratio 580, potassium 4.5, BMI 29. Now previous studies with Renal like Fidelity were not having any Indian, while here 133, so around 16.6 population percentage of population were Indian. So this was the first data of Indian subcontext for Finrenal. 46% of population were Asian. 88% were having hypertension, atherosclerotic cardiovascular disease in 28, diabetic retinopathy in 16. Almost all of them were on ACE inhibitor or ARBs, and 23% were on GLP-1 receptor antagonists. So what happened to urinary albumin create ratio? Once started on combination, there was a steep reduction in urinary albumin ratio, and that was most marked on in first 14 days. So there was 30% reduction within 14 days. If you continue at the end of 30 days, it was 35%. At 90 days, almost 50% reduction in UACR, and that was kept on lower side, say 52% at the end of study. And once these drugs were stopped, there was a rise in urinary albumin ratio to baseline. What happened to blood pressure and estimated GFR? So after starting this molecule, there was fall in blood pressure. In combination, there was fall by 7 millimeter of mercury. You can see this as a beneficial effect of combination also, as this group of patients are usually resistant hypertensive, and you can reduce some amount of antihypertensive if you use this combination. The most fearful side effect was fall in GFR. As you can see, there was fall in GFR in combination group by 7 ml per minute, but that was not persistent. At the end of 30 days, that fall in GFR reduced, and it was sustained it was maintained throughout the study phase, and once that was stopped, there was rise in GFR to normalcy. So this indicates two things. There is no persistent dip, so there is no development of acute kidney injury, and there is again normalcy of GFR that suggests it is a hemodynamic effect rather than nephrotoxicity of this drug. Hyperkalemia definitely were higher in combination group compared to empagliflozin, but they were lesser compared to Finrenal group. This must be because of caliuretic effect of empagliflozin. Though hyperkalemia was common in this combination group, any event like leading to hospitalization, serious adverse event leading to death were not found, and leading to discontinuation of the drug was equivocal in all groups. So what happened to Asian subcontext? So effect of this confidence Asia is a subgroup of same population, and to see any geographical or genetic variation on of a Finrenal or combination in group of type 2 diabetic CKD patient. So blue part is Asian countries, India, Japan, Republic of Korea and Taiwan, and red part 10 countries, European and North American countries. So proudly, India entered at last in this study, and it stood first in the Asia and second highest in the world after America. So 37% of population were Indian, 29% Korean, then Japan and Taiwan. So these are demographic of these patients. Dark blue is Asian and light blue is Caucasians. So estimated GFR were comparable. Atherosclerotic cardiovascular disease somewhat more common in Caucasians. Mean urinary albumin ratio were more say in the Asian part. So these were having this group of patients were having more sicker condition as far as kidneys are concerned, and more patients were there on diuretics in Caucasians. So diuretic may have affected their potassium thing in side effect part. So what we saw as efficacy, if we in Asian part as well as North American part, if we use combination, there is a dip in urinary albumin ratio or reduction from baseline was up to 53 to 56%. So that was comparable. So whatsoever might be the geographical variation, they act well. Though hyperkalemia was common in Asian group, discontinuation because of adverse event SAE or AE were lesser in Asian part. So we can say that these drugs are having better efficacy as well as well tolerability in Asian part. So in short, CKD associated with type 2 diabetes remains global issue, and they are always having higher risk of progression of CKD as well as development of cardiovascular event. Confidence trial provides a safety and efficacy point of view of combination of this therapy. Finerenone is an essential treatment pillar in CKD with type 2 diabetes. Its early combination with SGLT2 receptor inhibitor should be considered as optimal approach to rapidly reduce proteinuria and associated cardiovascular as well as kidney outcome. So having said that, you have to choose two things, means choose your patient wisely, and number two, once chosen you have to counsel them well before starting them on combination therapy. Thank you.
I think I will invite all speakers to be on dais and audience to have any questions, please.
So I have a question. So you have said that if EGFR is less than 60, then we start with the 20 milligram, and if EGFR is more than 60, then we start with the 20, and less than it is 10 milligram. So from the nephro point of view, is there any cutoff regarding the microalbuminuria? If macro is there, what level do you prefer? You start with 10 or 20, or it is solely based on the EGFR value?
So it is basically on EGFR, and now the concept is lower the proteinuria better it is. So whatsoever might be the level of proteinuria, if GFR is static or more than 60, you start with maximum tolerated dose. So 20 milligram, less than 60, 10 milligram. So we have to look the way I look from the Finerenone angle. So who do you start? So you start to every diabetic who has proteinuria, microalbuminuria. Every diabetic who's microalbuminuria, which means UACR more than 30, you need to put that patient on, provided, unless you find a patient whose EGFR is more than 90 and still has microalbuminuria, and you then probably are actually figuring out what is the cause, because then it's unlikely to be DKD to be responsible. Usually though they do go hand in hand. Sometimes I have discussed this in previous meetings where I've been told that it can happen, that you can have microalbuminuria, you have EGFR more than 90, but you should always be looking out for some other causes of microalbuminuria to rule out whether it's not. So that's every diabetic with proteinuria or any form of DKD you need to put. Number two, even if you don't have diabetes and you have patients with preserved ejection fraction heart failure, even that patient needs to be on Finerenone, and this is superior with failed data from spironolactone trials like TopCat, which actually did not yield into reduction in events. You here have an evidence with fine arts that Finerenone works in this subgroup of patients. So if you have a choice in a patient with preserved ejection fraction to choose between two MRAs, I would choose Finerenone. That's second subgroup. And third subgroup is patients where you want to prevent disease progression. Disease progression as in patients who have already worsened kidney disease, where you have macroalbuminuria and your EGFR is below 60, to initiate you can actually go right up to 25. There are very few therapies, especially MRA. I mean, practically everybody is worried to start. Spironolactone, how often do you start at 30 EGFR? You never start. But Finerenone up to 25 you can start. That's the initiation. And if it drops below it, you need to be watchful. You need not discontinue always. That's the other thing about it.
There is things, if you start early and if GFR even fall below 25, you can still continue with watchful eyes till 15 GFR as far as Finerenone is concerned. 1.5, yeah.
And one more thing that is a bit practical, that what is the correct method to check UACR and time of sampling And that is most of the time what happens, there are point of care strips that we do in the clinic, and that is depend on the color of the strip, and that is very objective. The one person is saying something else and other is saying else. So do we repeat on that point of care strip, and after we repeat in the lab again, and then we consider the microalbumin is or it is macroalbumin?
So basically, when to do or which is the ideal sample for taking UACR. So previously it was said that first morning sample that should be checked, but now it has been changed that any sample from any day, any part of day can be taken. So that is one of your. Second thing is to directly go ahead with strips. So that would be screening method, but if you want to have real confirmation, then laboratory method would be better choice. So once you made your diagnosis, if patient is not easily accessible for further UACR method or access to laboratory is not easily available, then you can follow that patients with strips. Otherwise, better would be in lab check.
My question, I mean, correct me if I'm wrong, if UACR by dipstick is positive, you surely have microalbuminuria. But if it is negative, you may still have microalbuminuria. Am I correct?
In non-diabetic patients, there is data for the reduced preserved ejection fraction and chronic kidney disease.
Absolutely.
In Renal.
Yes, absolutely. That's what fine arts is. It includes patients who are non-diabetic or irrespective to some extent who are on other therapies as well. But a lot of patients, I agree, were primarily driven by patients who had a lot of subgroup of diabetes in these. But irrespective of what A1C you had, irrespective of what patients' concomitant medications were, irrespective of what gender you were looking at, irrespective of that, this is one therapy that's emerging as a therapy of choice in patients with preserved ejection fraction. So class 1 is for SGLT2, there is no doubt. But everything else is, and class 1 is for diuretics, to decongest, but no mortality reduction.
Yes.
ARNI, GLP-1, etc. are still to find its place. ARNI is 2A, Paragon HF is the only trial missed by the whisker, 0.06 of p-value, but except that, fine arts is the first one that has come, and that's why probably you will find it now coming as one of the top recommendations for patients with preserved ejection fraction.
Thank you for the 3 talks. I just had one remark. I think we should stop using microalbuminuria and macroalbuminuria. It's just albuminuria.
I agree, completely agree.
Know about the presence of urinary tract infections also. So before stempling somebody as a albuminuria positive on the dipstick, we should always rule out urinary tract infections or significant uncontrolled hyperglycemia, because itself can lead to reversible cause, specifically in the microalbuminic range specific. Yes.
By definition, microalbuminuria is a bit tricky also. So everybody has a one sample and then patient concern will come and, sir, protein likha, let's start whatever treatment is there. But it's not always true. Many times you have a false report from the lab outside. Many times you have a concomitant conditions which increase the proteinuria. We might have some exertion, your clinic is at 4th floor, patient steps up and gave sample. You might positive for UACR microalbuminuria. Many times patient, as sir said, hypertension uncontrolled positive. Many times UTI, if patient heart failure is also not controlled, can give positive. So always one report has to be taken with caution. Always have a 2-3 reports before you start any treatment. So there is take home message, very important message.